Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd learning experience. HealthCast Vital Sync remote patient monitoring and the HealthCast Vital Sync remote patient monitoring ventilation dashboard should not be used as the sole basis for diagnosis or therapy and is intended only as an adjunct in patient assessment. Medtronic's medical education programs are offered to provide attendees education on the FDA, cleared indications and use of our products when applicable. The contents and conclusions of the following program are solely those of the speakers, unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers received funding from Covidian LP, a Medtronic company, for this speaking engagement. For this segment of the series, a discussion around acute care and wearable technology, the burden of under-monitoring on the floor. To help provide insight into this topic is Dr. Ashish Khanna, Director of Perioperative Outcomes and Informatics Collaborative at Wake Forest University School of Medicine.
This for me is a pivotal piece of information as I lead into all of my conversations around better postoperative care for our patients. And this data published in the Lancet in 2019 really shows why we need to be doing a better job, right? So intraoperative mortality is next to negligible. So our patients are sicker, older, they're frail, they have complex comorbidities. We take them through the operating room. Intraoperative mortality is in the decimal points. However, the same patients are not doing well when they go to the postoperative recovery period. This data suggests that postoperative deaths, if taken as a disease entity in and of itself, would be the third most common cause of global mortality, only after ischemic heart diseases and a cerebrovascular accident or a stroke. And this data is not just coming from the developing world, but also comes from the developed world, and is certainly not the only published piece of evidence. There's several other papers that describe the exact same pattern. So we seem to be doing a great job in the operating room, but specifically for the postoperative ward in the surgical realm, our patients do not make it home in the first 30 days after surgery. And I say the postoperative ward because then there's other data like this, and this is just a set of studies. There's more to it, but the highlights here are that patients die in hospitals, and they usually die before they get to an ICU. Adverse events happen on hospital wards all the time. When they do happen, they're responsible for up to 85% of all postoperative mortality. So patients don't do well in the postoperative period. Those on the floor particularly don't do well and are responsible for a large chunk of all postoperative mortality. And as I'll prove to you in the slides to follow, it's because of under-monitoring. Under-monitoring, again, takes me to aviation, and I've brought up this example several times in several of my talks. When you get on a flight, you all travel all the time. You go with the reassurance that aviation science and aviation technology has come to a point where there is extreme safety around aviation. And one reason why there's extreme safety around aviation is because every modern aircraft is equipped with a flight data recorder that records every single second of what is happening on an airplane. So there's no presumptions that are made. We don't go with the presumption that aviation is so safe that we can let aircrafts fly without flight data recorders. When things do go wrong, aviation learns from mistakes and problems. We are not doing the same for our patients on the floor. In fact, we're going with the presumption that patients on the floor are healthy and okay, so we don't need to give them their flight data recorders, which are their wireless wearables. When these patients crash and burn on the floor and come to the ICU as unplanned ICU admissions, then intensivists such as myself are struggling to understand what happened to my patient, what happened to this patient on the floor to lead to this final clinical outcome. We spend a whole lot of resources, time, and money. And more importantly, like aviation or unlike aviation, we don't learn from our mistakes because we don't have pattern detection. So that's why it's almost criminal not to have flight data recorders on our patients in the form of wireless wearables. And there's lots of data such as this one, right? So code blue events in a hospital don't really happen all of a sudden. If you go back and trace the history of code blue, they are accompanied by pre-arrest abnormal vital signs. The slide here shows increasing mortality with the increasing number of abnormal pre-arrest vital signs. As the number of abnormal pre-arrest vital signs increases, so does the mortality after a cardiorespiratory arrest event. Again, this tells us common sense, logically, that you should try and intervene 4 to 6 hours before an actual cardiorespiratory arrest. Only way you can do that is if you have improved monitoring on the floor. I used to fondly call this the 4 a.m. phenomenon because I used to do a lot of night shifts in the ICU. And it was right 4 o'clock at night that I used to get all these unplanned ICU admissions around the floor. And we actually published this and made this neat little cartoon where on the left side is sort of the national or the global standard for patient monitoring on hospital wards, which is very, very intermittent, once a shift, once in 4 hours, 6 hours. That's the patient on the left side. Is resting comfortably in bed, hypoventilating. No one checks in. When someone finally checks in 6 o'clock in the morning, this patient is ready to code and will not have a good outcome. On the right side is a patient with continuous wearable monitoring, with someone being alerted, intervening, and possibly saving ourselves from this really poor outcome for this patient. So the issue in broad terms is that our patients are falling off the so-called monitoring cliff. And I'm going to specifically give the example of respiratory rate, heart rate, and oxygen saturation. Let me take you from a patient who is in the operating room. So in the operating room, average surgical time these days is about 2 hours or so. We monitor respiratory rate, heart rate, and oxygen saturation continuously, beat to beat, on every single patient who undergoes general anesthesia. That's the global standard, right? The same patient comes to the PACU then. These three parameters are still being monitored more or less continuously in the PACU. Average PACU stay about 30 minutes to 2 hours. But as soon as the same patient goes to the floor, the same patient, okay, same 85-year-old with a hip fracture, who you monitored so closely while you were actually standing there at the bedside. Same patient is sent to the floor when you're not available at the bedside, and you take all monitoring off of them and you check on them once in 4 hours, once a shift. At best, you do it 18 times over the next 3 days, right? Look at the drop off and monitoring there. And then finally, this patient goes home and you say, okay, well, you now take care of yourself. We won't monitor you again, and good luck. And hopefully you don't come back to the hospital. I think, again, just talking about this, it makes me feel really weak, and I would not want this done on my family members or friends.
Please tune in next week for a new segment from this series wherever you find your podcast. This is the Medtronic MedEd Learning Experience. Thank you for listening.